Wow. So that's sounds so wonderful, Sarah. I mean, um, what an awesome experience, and it sounds like a plethora of opportunity.
And
So
we're just kind of getting started with our voice concentration classes at MGH, but we get a laryngeal speech, we get trach and vent, we get we get voice disorders, advanced voice disorders, upper airway. So we're starting all of those classes this spring, moving into the summer.
wow, wonderful. And which docs do you get to work with in Boston?
So at MGH Voice Center, which is where I have my GA fellowship and a lot of my like thesis work, I'm working with Dr. Zeitel and Dr. Burns. But in my placement at Boston Medical Center, I was with Dr. Nordzai and Dr. Tracy.
Okay. Wow. That's so fun to hear about. I mean, amazing, amazing opportunities. All right, Rachel, you want to share with us?
Hey, so I'm a little bit like Sarah. I also am a singer. I have a DMA in vocal pedagogy from Shenandoah, and I taught for 10 years at a university in Calgary, Canada. And I've made my name, my professional name, actually teaching singing to respiratory patients. So I did a ton of chronic cough and COPD and asthma and all of that. And I trained during my DMA with Wendy LeBourne and worked as a singing voice specialist for a long time. And COVID kind of made teaching online not fun. So I decided to go back to school. And so now I'm in London, Ontario. And I have two kids. You might have seen one popping through here. And yeah, I'm sort of in I don't want to say career transition because it's more a career addition because I was sort of already in this world, but now I'm looking for more clinical experience. And I noticed, as a singing voice specialist from the habilitation side, I was getting a lot of people who had like neurogenic conditions and swallowing issues that I couldn't help. So I'm actually looking for less work with voice and much more to learn more about everything else that goes on. But this is awesome because I really want to learn much more now that I'll have the two worlds combined.
Right, right. Wow. So did you get specific training to become a singing voice specialist, or how did you end up doing kind of working with injured singers?
So part of the training when I was doing my DMA was we had to spend a significant amount. We had a voice disorders class to begin with Wendy, specific for DMAs who were in PED.
Mhm.
And then I spent 150 hours in observation at different clinics. I went to Duke. I spent time out in Oregon. And then I spent time with Wendy too, just observing and learning, and then going from there to conference after conference after conference. So,
Well, that's wonderful.
just learning as much as I can.
That's great. Yeah, I love Wendy. She's awesome. Lucky you. All right. Liliana.
Hello, my name's Liliana Paulno, and I'm a second-year master's student at Purdue University. I'm originally from Northwest Indiana, so not too far from Purdue. And I actually started the SLP program thinking I'd wanted to work with children. And it was only over this past summer when I was at an ENT placement and had I had previously had the voice course that I realized how many different aspects of voice that I found really interesting and engaging and worthwhile. So we saw primarily, we actually had singers, we had theater students and professional voice users that I saw, and upper airway. I didn't get a chance to have a gender affirming voice client because there's only so many spots to go around per placement, but that was also something I was interested in. So I'm hoping to get more information on that aspect, and then also professional voice use.
Good. Awesome. All right. And some of the terms gender affirming is now the term for transgender. Is that correct? Yeah.
The
Yeah,
therapy.
that's
Okay, so my apologies for not using the correct terms. And we'll move forward saying gender affirming. Very interesting too that that you had just a big paradigm shift, just working in the ENT clinic. And were you just observing, or did you actually see patients, or?
we worked with patients. Yeah, I didn't really do at that point because I was like heading into my second year. It was pretty much all working with the patients. Yeah.
Oh, wow, what an opportunity. Okay, great. Let's see. Christina, I think you're next on my screen.
Hey, I'm Christina. I'm currently just starting my second year of my master's degree at the University of Central Florida in Orlando. I sort of got into speech language pathology because my undergraduate degree is in music. I'm a singer, and towards the end of my program, I started having trouble with hoarseness, fatigue, all the classic signs. And my voice teacher was like, "You need to see an ENT immediately." And they recommended some voice therapy. And after working with a therapist, I was like, wow, how cool is this? It's like working with the general public on their voice, not just musicians. It opened my eyes up to this whole other world. So after I graduated with my music degree, I started teaching voice privately, and toyed with the idea of whether I wanted to get a vocal pedagogy master's or go into speech language pathology. And when the pandemic set in, that really kind of locked in my decision that I wanted to take this other route. And I'm so glad I did, because I love my program, and I love speech language pathology. At UCF, unfortunately, we only get one specific voice disorders course, and it was sort of like a sprint the entire time. So I would just love to get more details on everything pretty much, and more like examples in detail. That'd be great. But through my program, we were also able to do an online certification in fees through Carolina Speech Pathology. So that was really cool. And then I was also able to get Speak Out certified, and I had a Speak Out client this past semester that I got to work with, which kind of shifted towards RVT and EMST later on, because he had some pretty intense hyperfunction. But yeah.
Nice, awesome. And in your voice disorders course, did they teach you any treatment programs, or was it just an overview of voice disorders?
We talked about some like resonant voice therapy and EMST, and we talked about a couple other things like SOVTs, but it was stuff that it just wasn't as in detail as I would have liked. And it was also some things that were familiar to me from my vocal pedagogy background as well. So just learning about more variety of things that are out there would be great.
Great. Blair, you're next on my screen.
Okay, hi. My name is Blair. I'm in Denver. Also have a singing background. Kate was my voice teacher for part of high school and my entire college career. I'm in my CF, currently in a high school, and also working with transition students, which is really great. But I got into speech pathology to work with voice disorders. So I am hoping to transition out of the schools maybe at the end of the school year, I don't know. So I'm here to refresh all that knowledge that I learned with Kate and in my master's program for speech pathology. And yeah. What else do you want to know?
I'm curious, well, you told me a little bit in the chat, in the Facebook group, but I'm just curious in general, like how prepared you feel in your CF with what you're working with. Do you feel like you have any tools? Are you drawing more on your singing voice?
Yeah, so my program, the way that they structured our voice class was that the first third was resonance, and then the second 2/3 was voice disorders. So we certainly talked about, SOVT and resonant voice therapy. We talked about conversation training therapy. So I learned a lot, I think, in that class, but I think most of my knowledge comes from my time with you and observing in other voice clinics. So I would say, could I jump in tomorrow and figure it out? Yes. However, I would love just more like continued knowledge and some exposure. Yeah, I mean, I had a few voice clients in my medical placement at the VA in Denver. And so I did some gender affirming voice therapy. I worked with chronic cough and paradoxical vocal fold movement. I had some just straight up voice patients. So, you know, I'm not like so out of it that I couldn't do it, but this will be good to just reorient myself.
Yeah, you have skills. In fact, you know, I think all of the singers here have an advantage over other clinicians who aren't singers who work in voice, because you learn so much about your instrument having to work with it, you know, in a very interesting way. So, so I think, so bravo for all of you who are here as singers and going into SLP. It's just a really nice marriage of the two, of music and medicine. So I've loved it for almost 30 years. I know you will. And my hope for starting this group is to really fill the gaps and give you confidence, and also share my experience of what I find to be like my favorite go-tos for a lot of different things. And my plan is to just break down the different disorders and kind of give you a cookbook of my favorite exercises. I obviously can't certify you in my colleagues' programs, like the Lesak Madsen resonant voice therapy is definitely Kitty's baby, and you have to be certified. But she does do certification online, and you can order the manual, the clinician manual and the patient manual on Amazon. And LSVT and those other programs that are research-based and very strict in their clinical use also need to be through Lori or through LSVT. But I might be able to organize something for our group, since Lori and I are buds. So, all right, let's see. Maddie, did we hear? Yes. No, we didn't hear from Maddie Seymour.
I was a few minutes late, so I'm sorry if I missed anything, but I'm just getting the gist that we're all introducing ourselves. So I have no singing background. I felt like voice was kind of just for singers. And then one of my clinic instructors mentioned she was teaching a class for professional voice users. And I was someone who my throat hurt and I lost my voice at the end of every single day when I talked a lot. And so I signed up for her class, and it was mostly professors and teachers. I learned so much about using my voice and resonant voice and kind of being the patient, and I loved it. And I'm a yoga instructor, so I also learned about like laryngeal massage and stretching, and I love that aspect. So then last semester, I got to do a placement at an ENT and a cancer center, and I did like voice and upper airway, a lot of PPFM, chronic cough, muscle tension dysphonia, and also had a neck cancer. And I realized that was what I wanted to do. So now I'm a second year. I'm at University of Arizona also. So I'm applying to CF, well, I'm kind of starting to apply to CFs. And one of the things I want to learn more about, which may not be helpful for everyone, is more like the musical side. Like when I had singing clients, I felt like it was harder to kind of maintain face because I just don't know a lot of the vocabulary, that kind of thing. So yeah, so I'm really interested in head and neck cancer, but I also like voice and upper airway and all that.
Okay, great. Well, considering the population here, I think we can all help you get a little more well-versed in the singing terminology, and you know, maybe you can even do some singing lessons on your own and get a little bit more idea about voice production. I think that will help you in your clinical work too. Just the more you play with your own instrument and understand it, the better embodied you are with that information. And I think the more the more easily you'll be able to teach that to your patients.
Yeah, that's something my supervisor and I talked about a lot, is that maybe over the summer, if I have a break between school and in my CF, I could do some singing lessons. So I learned something, because at the beginning, it's like, since I'm not a singer or a performer or anything, and I had to model like sustained awe, it felt like the most embarrassing thing, because it felt like singing. So it's definitely something that I'm gonna look into.
Okay, great. Awesome. Lauren.
Sorry, I'm just getting over COVID, so I might be a little hoarse right now and coughing. So I apologize for my own voice, but I have been a speech pathologist for the last 15 years. 6 of those years, I worked at Temple University Hospital in Philadelphia. A lot of the time I was studying under the ENTs there 2 days a week during my time at Temple. So I got a lot of training with them, doing strobes, fees, working with the voice patients, doing the evaluations and therapy. And then after I left Temple, I came back home to New Jersey, and I am now an independent contractor at an ear, nose, and throat doctor's office we currently have 5 ENTs, I think. And I am the only speech pathologist there. So I basically kind of built the program for them. I do all their strobes, their fees, all of their voice and swallowing evaluations and therapy. I see adults most of the time. I would say 90% of my population are adults. 10% is pediatrics. I don't really have much experience in pediatrics. So a lot of the therapy that I do with them has been kind of self-taught based on what I know with my adults. Some of the evaluations are a little more challenging with my pediatric population, and I feel like I need reference for norms with them, which I've tried to research on my own. I also see a lot of singers, though myself, I'm not a singer either, but my cousin is a professional singer and vocal coach, especially for young adults. So I have sat in with her on some sessions. I have asked her a lot of questions when it comes to singers. So she's kind of been my go-to a lot when it comes to singers. So I've gotten a lot of education from her, as well as my own patients. I just sort of ask them lots of questions about their technique and breathing and their training. And so that's sort of where I'm at this point. More kind of assistance with pediatrics, and same as Maddie was saying, more with singing patients. I do see a lot of cough, paradoxical vocal cord motion, and then the traditional voice patients, paralysis, paresis, nodules,
Right.
And I also do a lot of hands-on myofascial release. I have training in that as well. So lots going on.
That's great. When you work with singers, are you working with their speaking voice, or are you working with their singing voice?
So it's both, but most of the time they're coming to me mostly for their speaking voice, and then they're noticing trouble with their singing voice. So I focus on their speaking, and then we are going into the singing, because a lot of times they're getting frustrated, like, oh, my speaking voice is back to normal, but I'm still having trouble in this range. And so I try to help them the best that I can. And then I always refer, if you know a vocal coach that can help you with this part, perhaps it would be better for you to work with me and the vocal coach at the same time, because I'm not a singer. And so I'm honest, and I want them to get the most out of their therapy and what they're looking for in terms of their goals,
Right. No, I think that's really helpful. Oftentimes, because I wear both hats of singing voice specialist and the voice pathologist, I prefer having someone else work with the speaking voice if I'm working with the singing, because there's not enough time to do
Right.
both.
Right.
And yeah, so really interesting. Where did you learn the myofascial release, or the training?
Walt Fritz, I took one of his courses.
Okay. I just saw he was in Hawaii this month.
he came to New Jersey, so I kind of jumped on it, and when he was in town, and his course was amazing. It was super interesting, and it has really, really helped a lot of my patients, like more than I think just our traditional therapy techniques that I've done, because a lot of them have like muscular pain and they can't really figure it out. And as soon as we get through a couple sessions of doing it and I kind of teach them how to do it to themselves, it's amazing how much better they're feeling. And mentally, I feel like it's helping them.
Wow. It's so funny because I really was just looking into taking his course, and I saw that I missed him in November in Denver. So that's good to know that it's a good course. I might check it out.
Oh, definitely worth it.
Awesome.
I took it as well and it was awesome.
Really?
So,
Oh,
yeah.
Very cool. All right. I love you guys already. Heather.
Hi, sorry, I joined a little late too. So my name is Heather Henry. I've been a speech pathologist since 2005. I'm currently working outpatient for a big hospital system down here in South Florida. And I got my initial voice experience in grad school at UCF with Barry Hoffman Reddy. So Christine, I'm sure you know her. And I did a master's thesis with her, worked for a number of years. And then I sort of felt like, oh, and I started taking singing lessons very late in life, like starting in my undergraduate studies, because I just didn't have the confidence when I was younger to really do it, even though I loved singing and my parents didn't encourage me. Speaking as a mom, I have like very strong opinions about this now. But so I started taking lessons then, and then I decided it was just really hard to get into voice at that time. So I started a PhD with the intention of doing voice. And unfortunately, with my advisor, it was not a good fit. So I ended up transitioning to a different area. And then after my first daughter was born, it just ended up being impossible just based on the program requirements being so rigorous and full time and not being able to afford childcare. So I ultimately stopped that. But it ended up being a good thing because I wouldn't have focused on voice. And after that whole experience, I came back out of it like, no, I really want to do voice. This is totally my passion. So if anyone does a PhD, having the right mentor is like super, super, super important. But I've taken lessons with Brian Gill when I was living in New York, and he's amazing. And he changed my voice. And I actually just recently started learning with him again because I haven't taken lessons probably for like, I don't know, 9 years. And so I just missed it. And my oldest daughter is a performer. She's 9. And I'm just trying to cultivate her skills and just trying to learn from her by just encouraging her and just knowing what I know being a speech pathologist. But at my current job, I work with a lot of voice patients. I would say about half my caseload is voice. The other, everyone else is like, stroke, TBI, degenerative diseases. But the ENT I work with, it's basically like she sends me referrals. I don't actually do the strobes. I don't do the instrumental assessments. And that's something that I really, really want to do. So this year I'm trying to take steps to try and gain those skills and thinking maybe doing private practice eventually. If I can't make a position possible either within my organization or somewhere else. I would love to work at an ENT office. That would be amazing. So, and I want to learn a lot more about singing. So we've got a huge group of singers here. So that's amazing. And I really wish I had a degree in singing, honestly. Like I'm so like, wish I could go back and do that.
Well, your mentor, Brian Gill, is one of my favorite people. And he's as nerdy as I am when it comes to like just geeking out on voice information. So if you ever have any questions, he's also a good person to turn to.
Totally. Yeah. He's amazing.
That's awesome. All right. I think Mercedes, are you with us? Your camera's off. Oh, there you are.
Hello.
Hi.
Hi, my name is Mercedes. I'm a clinical fellow at City of Hope Medical Center in LA, and I currently am doing inpatient and outpatient. I work with some voice patients. Also, right now on my outpatient caseload, I have a singer, and I have another patient who does podcasts every day. So but when I was when I was in grad school, I was able to be a part of the gender affirming. We had a gender affirming voice clinic, and so I joined that. So I learned so much from that clinic, and I also volunteered for the speech pathologist who ran that clinic. On my free time, I did that as well. And when I was younger as well, I was in choir, and I would do singing. So that's just where I'm at. I just want to learn as much as I can, just because like at the hospital that I'm at, we specialize in cancer. So all of our patients have cancer, and I'm the only speech pathologist right now, or going to be speech pathologist on my team, that's passionate about voice and want to learn as much as I can. So they kind of want to give all the voice patients to me because they all love dysphagia and, you know, and laryngectomies, and like that's their passion and their focus, and I love that too. But I just really want to keep up my voice skills and provide my patients like with the best that I can, and I don't want to lose all the knowledge that I gained from grad school. So I just want to keep learning.
Right, right. Do you feel like you're supported, like that you're actually getting supervision and guidance as far as programs, treatment programs, approaches?
Yeah, well, my supervisor, she does all of the video strobes. I'm not doing any of that. She does all that and then kind of tells me the plan, and I'm doing all the therapy. So she checks all off everything that I do. So, but I really wanted to be able to do video strobes on my own.
Yeah.
But she's my supervisor's great. She was at the VA, and she has a lot of training as well in voice, but it's just not her passion area, I would say.
Okay. I'm curious, who was it that said they had these course online?
That was me.
How did they do that?
It was a lot of videos, so it was informative. And so that was good. And I'm glad that because it was free, they paid for it for my entire cohort. So that was great. And I think it was to kind of make up for the fact that our swallowing lab and voice lab aren't really a thing right now because of COVID. So I mean, it was helpful, but it's just watching videos. So we did have one day where we actually got to use rigid scopes on each other and experiment. And I was the guinea pig, so I got scoped like 25 times. So that was also a good experience too that we had.
Oh, man, I was that person. Oh,
Yeah. I was like, I've had this done before. It's fine.
I even sang an aria with a flexible scope up my nose for like people. Like, okay.
Yeah. Mm-hmm.
Well, that's great. I think did I get everybody? Yes. Okay. One of the things that's interesting right now is COVID, and we're not like most of the people I'm seeing, except for a short period of time, and just a few individuals I'm seeing in person. How are you able to do your evaluations, or how has that changed for you?
I can go. So my evaluations really haven't changed. Initially, when COVID was sort of at its peak here in New Jersey, we were getting everyone COVID tested before I would scope them. I also was pregnant at the time, so I was very, very hesitant to scope patients. Obviously, I have, I had a gown on, I had glasses, I had a N95 mask. The patients had to get COVID tested and quarantined for 3 days prior to their evaluation with me if they were getting scoped. Since then, COVID sort of calmed down a little bit, but now it is back at its peak over here in New Jersey. Literally everyone is getting it, including myself. So I don't know if we'll go back to testing everyone. It sort of was an inconvenience to test everyone and get the results back and wait for the results and then have them quarantine. So I just don't know how realistic it is. I do have like an air purifier in the room. I have a plexiglass that I kind of sit behind at my desk. And also, I'm still wearing the same protective gear. But yeah, it's risky, especially during fees, my cough patients, all of them. It's been really risky. And I'm sure this is how I got COVID from work, but we don't really know. But yeah, it's been tough, to be honest.
When before COVID and when you were doing your clinical practicums or when you were working in clinic, how much of your evaluation included touching the patient? Anybody? None? Some?
I mean, I'll touch patients to do like myofascial release type work, that sort of stuff, but maybe with posturing a little bit. I don't touch them as nearly as much as like physical therapists. I work in outpatient rehab, so I see what the PTs are doing a lot, but I mean, I just think what makes our job really dangerous is, again, just the aerosol generating procedures that all the patients are doing. I've been wearing an N95 and goggles and a surgical mask over that. I wish I had plexiglass. I don't. And I initially, like when I was doing EMST with my patients, I didn't do it at the beginning of COVID. Now I am. Pretty probably sort of dangerous, but I have them face away from me and I just watch them. And it's actually, I'm finding it to be a better position to see them in general with voice work, looking at them from the side oftentimes.
You can see the posture.
Yeah.
Do they use their own device or do you provide it and then clean it?
No, they have their own. It's a one person use device. So I, ask them to buy it and I tell them why I think it would be helpful. But it's definitely risky. I've had to tell my boss a lot, like, do you understand what I'm doing? Like, because I feel like she's no idea. I haven't had COVID yet, but I don't know. It's quite possible.
Well, one of the things that I have been shocked about just getting referrals of other patients is that often the larynx isn't even touched. And I feel like it's sad that someone has to go through like 6 or 7 doctors and speech pathologists before they actually get to somebody who touches their larynx and finds out that there's a problem. So one of the things that I wanted to talk about today was really how to assess physically, even though I know we're not really touching our patients right now, but if we can get good at it ourselves and really understand how to feel the hyoid, how to feel the thyrohyoid membrane space, and even how to instruct your patients over Zoom, if that's what you're ending up doing. It's a huge part of the body, and there are so many connections to so many different places in the body that muscle tension patterns can impact, that the tension itself can impact the function of the jaw, the tongue, the larynx. So it's something that I think I really want to hit home because I don't want to see that happening in the future. Like, I just want everyone to feel really comfortable with this information. And I know Heather and Lauren, those of you who are trained in myofascial release, I know this is going to be a big review for you, but does everyone feel like that's something that they could use a little more information on? Okay.
I also want to echo that something I forgot to say in my introduction, which is that I'm Alexander Technique certified. For those of you singers and musicians who know what that is. But so I actually finished my 1,800 clock hours of certification during the pandemic. And what was really interesting was that switch from touching a person to just doing it visually through Zoom, and what I could notice about the muscular tension just with my eyes. And that really carried over into my placement last year when we were doing we would go in 1 day a week and do evals, and then the rest of the therapy was done telehealth. And it was really interesting to just have to pick up on these muscular tension all over the body when you're doing it through a screen.
Yeah, wow, that's amazing. One of the things that, I'm so much on board with that kind of discipline. I'm training right now for level 2 Franklin method, which I don't know, does anyone know what Franklin method is? Except for Blair.
Isn't that the thing with the balls, the Franklin balls?
Super balls, yes.
Yeah.
But basically what it is a study of anatomy and physiology, but functional anatomy. And you actually learn how to find, the body and the bone rhythms and the way things move and work, so that you find the most efficient way of moving, and you can use guided imagery or even simulation of movement, kind of like Feldenkrais. You can think through the movement. So if you have patients who have physical limitations, you can still use imagery to help them improve their movement. And it's not so much an issue with, because I think this is used a lot with physical therapists, Pilates teachers, and dancers. But what I've found is just learning the different connections of the body and how to release tension really quickly is so helpful at the beginning of a session with a patient. And so I'm gonna share with you some of those little gems. And the other thing that I think is important about the Franklin method, which I just feel like if you can really embody yourself and you can teach your patient to really feel their body, then they are more successful at making a change. Because if they really are not able to assess what they need to change, it's really hard to get them to change. And I think that's true in general with anything that we're setting up as an objective for our treatment plans. You have to be able to identify it first. And sometimes, I don't know if you've had this experience, but I'm amazed at how disconnected people are from their bodies. And so my hope is to share that with you too, just to give you an augmented experience that's unique, unique to anything that you've learned in school. So what I'd like to do is just do a little physical warm up, take you through some release exercises, and then talk about the hyoid and the larynx and the muscles and the attachments and how that makes a big difference in what we do in seeing voice patients. How's that sound? Good. All right. So if you don't mind standing, actually getting a little warm here. So what I'd like to do is just start with a little tapping. We're going to do a little tapping up the right side of the body and down the left. I won't be mirroring you, but that's the direction of digestion. So that's the way we go. And then we're going to move up to the chest and lungs, diaphragm. And then move up the sternum and the back of the neck. I don't know if I've lost my head in. And up to the skull, the forehead, over the zygomatic arch, down the masseter. And let's do a little crimping of the mentalis and along the mandible, like you're crimping a pie crust. And let's just do a little tapping of the legs. You can be a little firmer on the legs, go down the front, down to the toes, and back up the front, down to the sides, back up the sides, down the back. And let's do a little gentle glute punch. And then move up to the lower back and let's add a little voice. And let's go back to the diaphragm a little bit. Add a little voice. And now just take in your body. I'm going to take a minute and just sense the body, sense your breathing, your posture, without judgment, just noticing. 3, 2, 1, and begin. Three, 2, 1, and we're back. How'd everybody do with staying present in that moment of checking in? Who felt like pretty good? You were able to be present most of the time. Who felt like I was thinking about what I needed to buy for dinner tomorrow night or my laundry list? Anyway, well, most of you were able to stay pretty present. Just taking this little moment, I felt like is a good thing to teach your patients, especially if you have singers who have stage fright. Being able to do something physical to kind of get the brain and body connected a little bit, but also to quiet the mind is a really nice thing. But it's also, if you check in and you think, wow, I don't feel that great, or I'm feeling sore, stiff in part of my body, you can kind of decide what you want to do to make that better. So I want to just finish up with a little tapping of the arms, and we're going to start with I'll start with my left arm, you start with your right arm, and we're going to just tap up the arm all the way to the shoulder and back, and you can move your arm in space. I want you to focus both on the arm that's being tapped and also the hand that is the tapper. And now we're going to just brush away any tension. And now just shake it off, shake it away. And if you can, shake the leg on the same side as the arm. And you can't see my leg, but I'm definitely shaking it. All right, and now just do a quick comparison between sides. Let's just stand on the side we just tapped and stand on the other side. Anyone notice a difference? the side on that we just tapped feel better? Maybe a little more organized in the core, a little bit more flexible in the knee. Sound familiar? Yeah. All right, let's even it up. Do the other side. And brush. And shake. Shake the leg. And let's do a quick comparison. So let's see if we feel better on both sides now. Everyone feel like they made an improvement? Great. So what we just did is we increased the body-mind connection by awakening the proprioceptive organs in our body. And the more information, the better the navigation and the better we feel in our bodies. And if you take Kitty's course on the Lessig Madsen resonant voice therapy, she starts out with like a shaking of the shoulders to just free up the body. And this is my version of that. So it's just awakening the whole body. And I don't know about you, but I feel like my posture is better. My chest is more open. My neck feels, just nice and free and open. My feet feel like they're more firmly planted on the ground and I'm getting information from the ground. And that's a really nice place to start when you're going to work with a patient. And I do work mostly with people standing versus sitting, because I feel like we're more awake, we're more present, and we're more engaged. And also, especially with singers, we're mostly standing when we're singing. So that's another reason. But I even my non-singers, I have stand and get their body engaged. I'm going to teach you a quick head and neck and shoulder release exercise. And this is great for all patients, but especially voice patients. So we're going to start with the back of the neck, and we're going to overlap our hands like this. And we're going to just do a little neck sponging. The fascia in the body has a lot of water. So when we think about squeezing the fascia like a sponge, it's not so far-fetched. So if we squeeze the neck and do a little head flexion, we're squeezing out the water in the sponge, and then as we release, we float up, the sponge fills back up, and we're ready to go again. And just make sure that you're breathing and your knees are nice and soft as you squeeze and release. Float the head back up. One more time. Squeeze and flex and float and release. And just notice how much more free the head and neck feel back here. You can do lots of different variations. You can do side to side flexion. You can do squeeze on the lift. But you can see just 3 sponging and it's already different. It's already nicer, freer. Let's do a quick thing with the shoulders as well. So we're going to put the thumb on the neck and squeeze the shoulder blade as we lift the shoulder. So it's almost like giving yourself a little mini hug. And then release. And squeeze. And release. And sometimes when I release, I like to bend over and just kind of tassel, shake the hand and arm. Squeeze and release. And last one, squeeze and release. And then you can do a quick comparison. Anyone feel more relaxed on that side now? Yeah. All right, let's balance ourselves out again. Let's do it. Squeeze and release. Squeeze. Release. Squeeze. Release. Squeeze and release. Okay. I don't know about you, but I feel much better. Everyone else feel a little bit more open and released and relaxed. And all right, so let's find our hyoid bone. So my favorite thing, well, if you think about where the hyoid exists, it's sort of where the floor of the mouth meets the neck. So you can palpate down the tongue base and then find its base, which is the hyoid. Or you can go from the thyroid cartilage, find the thyroid prominence. And if you walk your fingers to the side, you'll feel the thyrohyoid membrane, hopefully. And then right above it is the hyoid. And it's movable. So you can move it, wiggle it a little bit. Everyone finding success with locating their hyoid? Yeah. Now, does everyone feel a decent amount of space between the hyoid and the thyroid cartilage? Can you stick your fingers in there? Yes, everybody? Good. This is one of the ways to do the circumlaryngeal manipulation when you have patients with functional dysphonia or aphonia. Nelson Roy does the anterior press into the, it's kind of, because oftentimes what happens is the whole larynx comes forward and up. So, and then people just completely lose their voice, or their voice gets super high pitched because the lifting of the hyoid, basically the larynx and the hyoid together, creates that lengthening of the vocal folds. So you get this super high voice, or sometimes no voice at all. And so, so that it's not so traumatic to the patients, I will use a slide from the tip of the chin down to the hyoid, and then a press posteriorly. And then usually you can get a little bit of space. Sometimes you have to kind of work your fingers in that space, in the thyrohyoid space. And then you can pull the whole larynx down. If you have somebody who's had years of no talking, this might take an entire hour for them to get their voice back. Has anyone worked with a patient with functional dysphonia or aphonia thus far? No. It's actually one of the most rewarding experiences to give somebody their voice back. Because oftentimes you are not the first person they've seen for this. And I had actually had one person who hadn't spoken for 7 years. And so it took an hour to get their voice back. And then it took them to do, I gave them exercises to do at home to maintain the release, which is really just sliding the hand underneath the chin to the hyoid. Well, usually the hyoid and the thyroid are much higher. And then press in and then down. And the little flap of skin here between the index finger and the thumb catches on the thyroid notch, thyroid prominence. And then it helps bring the whole carriage of the larynx down. Can you feel that as you do that to yourself? You have to actually press in hard enough that you sound like Marvin the Martian for a moment, and then move down. Is that similar to what you guys do, Lauren and Heather? With your myofascial release?
Yeah, so I will have them actually palpate around the thyroid cartilage, like to find the actual notches
Okay.
on either side. And then I'll have them sort of just do like a slight pull down right at that area. And then exactly, yep, kind of like in and down. So I kind of teach them like it's like a Y instead of them squeezing in, so they're not, you know, losing their breath or feeling like they're suffocating themselves. And then I hold it there for 3 up to 5 minutes at a time.
Yeah. Great. Yeah. So that was the next step, is just getting oftentimes when you first get the patients, there is no space. So you have to create the space. And usually it's kind of a combination of press in, down, find your fingers in the hole. And then, yeah, can be super painful for the patients, especially if they've had years of chronic tension.
I also make them evaluate their pain level. So, you know, I'll ask them when I'm palpating, scale from 1 to 10, where are you when I'm touching? How much is my pressure? On a scale from 1 to 10, like I might feel like I'm doing a 3, but you might feel like I'm doing a 7. And then I have them assess my pressure versus their pain tolerance, or what pain they're feeling. And then we go from there. So I'll do it initially. Okay, let's do our scale. Let's do the stretch for 3 to 5 minutes. After the stretch, we assess again. What was your evaluation at this point?
Yeah, great. Wonderful. Heather, anything to add to that?
Yeah, that was great. And then also what he taught is having the patient tell us if, like, how it's feeling in terms of, does it feel helpful? And telling sensations that they're feeling, asking them, does anything feel familiar? Maybe it reminds them of the voice tension experiences that they sometimes have, even though we're providing releases. But again, asking them, is this helpful? And then I ask them, like with the number question, like, okay, this is your number. So what number would you stop me at? So I know like how much further I can go if they want me to. So a lot of it is patient guided.
Good. Yeah, it's really important to get the patient's feedback so that you're not pushing them to a point where they're not going to come back and see you again. And I always warn them that it's not going to feel comfortable, but that we can stop at any time. And I try to get the voicing in as quickly as possible, as quickly as it returns. And that's another really important part of this process, is we're usually doing this kind of significant circumlaryngeal reposturing because there is no voice or it's severely distorted. So the idea is to get the voice back as quickly as possible. And you can do humming, you can or you can do inhalation like that. Or sometimes you can just do reflexive kind of little gentle cough to kind of get the voice going. Anything reflexive, laugh, cough. The sound tends to be a good one. And then just stick with it. And then homework is really, to continue with the massage as long as they can every day until their voice stays stable. So it can be pretty tricky, but it's so great when they do get their voice back, and then they have this tool that they can always use if the voice starts to go back to the old. But this is one of the things that I use all the time, and not just for patients with no voice or super high pitched voice. I use this even with my singers who are having trouble with any like tension as they go up into the upper extension, especially, or even just if they're maybe not using their support mechanism well and they're starting to use the accessory muscles and that space is going away. We'll even sing with the fingers in the thyroid membrane space. Inhalation is always a good way to increase that space. So just inhaling, sticking the tongue out forward is another good way to find a little bit more space in here. Do you feel that, everybody? And what I would say is the more you can practice on yourself, the better you're going to be on someone else. So, you know, you can't really overdo this. If you're getting really deep and crunchy with your fingers in there, it might feel sore. But, you know, you're not anywhere near anything that we need for phonation. So, I mean, the vocal folds are way down here when you think about it. So it's really a pretty safe thing to do and a pretty safe thing for the patients to do if you teach them to do it well. And I like this because once they get the larynx down to a more healthy position, this does help reduce the larynx even more, but it's not as like strangly as some of the other things that you can do to release the larynx and the hyoid. And it just seems more comfortable. And also you can have them stabilize their hand right on the clavicle and sternum, top of the sternum. And that helps make it harder for the accessory muscles to be successful at engaging for voice production purposes. So it's a nice tool to have. Does anyone remember all the different attachments of the hyoid? Like where, we know that it sits at the base of the tongue and that's sort of its movable base, but what else do we remember about the hyoid? And just feel free to unmute yourself and talk.
I remember it's in a sling.
Okay. Yeah, it's a tensagral bone that it's not attached to another bone or a joint. It's attached only by muscle and ligament, right? So they call it the floating bone, but it's not really floating. It's suspended is a better way to think of it. So we've got the tongue attachment. Any other structures you can remember? Well, we know it's connected to the larynx through the thyrohyoid membrane. So there's that attachment. So we've got larynx, tongue.
Styloid.
The styloid process of the jaw, exactly.
Mylohyoid, geniohyoid, hyoglossus, thyrohyoid.
Sternohyoid.
Hyoid, yep, the sternum. And what about the omohyoid? Anyone remember where that attaches?
Shoulder.
The shoulder, right? So how could that possibly, you know, if you've got somebody with severe muscle tension, you usually have tension in the shoulders, the neck, the jaw, the tongue, the larynx. And so the hyoid is involved in all of these things, which is why I think it's so important to know and to know how to release and to know and to release the other surrounding muscle groups that are involved in the hyoid, which is why we started the way we did tonight with the sponging, the release of the shoulders, the neck. And then we'll talk a little bit about my favorite little direct massage release exercises. Let me just quick share my screen here. You guys see that okay? Awesome. So this is what it looks like in case it's been a while. It's a U-shaped bone, and we've all successfully found it, which is why I kind of threw it up there. So here's a nice visual. You can see that the floor of the mouth is formed by the muscles that attach to the hyoid. So you've got the myohyoid, the stylohyoid, the digastric, anterior and posterior bellies of the digastric. And what functions did those play, do you think? Are they depressors or lifters?
Lifters?
Lifters.
Right. And then below, so here's the hyoid, then you've got the sternohyoid and the omohyoid going back. They kind of put it on the scapula in front, but it's behind on the scapula here. So much more in depth than we really talk about in voice disorders classes, right? I don't remember, well, I mean, it's been a while, it's been a minute, but I don't remember really focusing on this at all, but you can see how all the different structures are really a big part of this. And then you've got the mastoid process here, which what are the main attachments of the muscle is? Do you remember what muscle attaches to the mastoid process? Rachel, you said it, but you were muted.
Oh, sternocleidomastoid?
Exactly, sternocleidomastoid. Another big player in the tension in the head and neck, right? And I'm going to show you how to release that too, for those of you who are not in myofascial release. I had a principal of a school who was a big talker, and I showed her how to release just gently because she was so sore I could barely touch it. But she said it made all of the difference in the world to be able to release the sternocleidomastoid. So, but here you can see, I like this little picture where you can see the attachments to the jaw, the styloid process. You don't see the mandible, but and then you've got the thyroid cartilage, the sternum, and the scapula. This is a Franklin method illustration by Eric Franklin. I thought it was really cool to just see the attachments of the floor of the mouth to the mandible, but also suspended by the hyoid. And here's the other muscle underneath the floor of the mouth. And then you've got the tongue and how it's the base of the tongue here, and then it's got its attachments to the temporal bone, the styloid process, and the jaw. So really quite in depth. And this is just another look at the elevators: the geniohyoid, mylohyoid, digastric, stylohyoid, and thyrohyoid. And I think it's worth knowing where the muscles are from a clinical point of view, because when you want to release them, you really want to know what you're palpating. And so that would be my suggestion to you. You don't have to memorize the names, but you really need to know where they are. And this is also a Franklin method illustration where you can just see sort of this sling from the styloid process to the hyoid to the scapula to the sternum. I mean, it's quite involved. And here you can see the omohyoid. So we know that the hyoid is a movable base. It moves. And one of the things that I found interesting is that if you think about moving your head from the hyoid, it seems like there's a little bit more range of motion than if you just moving from the neck muscles. So it's a nice image to just feel like that is the pivotal point. And obviously, it's suspending. It's the membrane between the hyoid and the larynx is really suspending the larynx in the body. And it is movable because it needs to move up for swallowing, right? So, and it also helps open the jaw. And it aids in chewing. And it aids in voice production, just because its role between the thyrohyoid, the hyoid bone, and the whole body of the larynx. And we talked about this a little bit, but one thing that you might want to realize is that the relationship between all of these parts where they're attached is if you're tense in your jaw, clench your teeth for just a second, and now move your head from once just to the left side, back to the middle, and the right. And now release your jaw. Notice a difference in the quality of movement. And the same thing is true with the tongue. If you tense your tongue, the movement becomes much more challenging. So I just think it's an underappreciated body part. So these are just some little exercises you can do with the hyoid. One is just wiggle it. The other is put your fingers on it and then wag your tongue and feel the movement. And then this is a nice little stretch. If you take your one arm and cross it over to the scapula and the other finger on the hyoid bone, and just depress that shoulder and look away with a little bit of upward motion on the hyoid. And breathe. And release. Again, stretch as you press down on the shoulder. And release. One more time. Press down on the shoulder as you stretch and release. Now I know this is weird, but do you feel a release and openness here? So this is something that you can do, again, really quickly in therapy and teach the patient, and they can do this at home, but it doesn't take a ton of time to teach, which I think is really helpful. So let's do the other side. So we're balanced, press. And release. Press. And release. One more time. Press. Release. All right, great. And now I talked a little bit about this when we were doing the digital reposturing. But you can press up into the floor of the mouth with your thumb and just work from the tip of the chin all the way to where the floor of the mouth meets the neck, and you're at the hyoid. And you can go back and forth like this. And this is something that I teach my patients to do too, so that they're not carrying a lot of tension in the floor of the mouth. And you can also take your fingertip and work right underneath the edge of the mandible, where those fascial connections are and muscular. And then the other side. And there might be soreness if someone has a good degree of tension, and it's okay to warn the patients. I think it's important too, so that they know that it might feel uncomfortable. And again, the cue is, if it feels sore, back off on the pressure and just gently release. And then I like to with clean hands, you can do a tongue massage on the inside of your mouth. And so I use the thumb and index finger again, and you just press, and it can be really intense. Puff, release. And you can do about 4 of those on the outsides of the tongue, and only about 2 because of the lingual frenulum. It's best to do this in the shower with clean hands, and you drool a lot, so it's just a safe environment to do that. But I find that the patients benefit a lot from that direct release. And then there are the 2 main players in the jaw joint. The muscles that impact the jaw the most are obviously the masseter, or your chewing muscle here, and the temporalis muscle. So there are a lot of different ways of releasing the masseter. I like just gentle stroking along the muscle. It's a good one to start with. Some people use the fingertips, others use the heel of the hands. For me, that's a little more impactful. And then as far as the temporalis, I like to do a little finger pad press and circular massage. And I call it the search and rescue mission, because that muscle is huge. It's a huge fan-shaped muscle. And it's not always sore everywhere, but where it is sore is where you need the release. So, and again, if you want to teach your patients to gently bite down, they can feel where the muscle is. And then they can work around the skull to feel for any soreness. And then I'll do the same thing at the skull base with the pads of the fingers to release. And also in the neck joint and upper trapezius, press, circular massage. And you can actually work your way down to the medial traps. That's what I call the direct massage release series. You can also do tongue stretches, but I like to support the jaw joint. So I press to the side of my face and stretch the tongue. And I usually just breathe for 3 to 5 counts with the tongue in that position. And then slide to the corner of the mouth, slowly. Back to the midline. And other side. I also like anchoring the tongue tip behind the bottom front teeth and stretching the tongue forward. The reason I think it's so important to support the jaw joint is that if you have a patient with temporomandibular joint dysfunction and they don't know it, it can really be painful and it actually can pop out the joint. So just stabilize when you do these, and it's safe for everybody then. And I give this to every single voice patient because every one of us, even the therapists, need to take care of the mechanism, and just making sure there isn't any unnecessary tension is a really great place to start. So you've got the neck sponging, the shoulder sponging, the omohyoid stretch on both sides. You have tongue release, jaw release, neck release, trapezius release. And I can actually email you the handout I use if that's helpful. So you don't have to, okay, I'll send you the handout. So this is just a review of the circumlaryngeal manipulation we did earlier in the session, so that you're really feeling that, palpate the muscles from the floor of the mouth to the hyoid, anterior posterior pressure, get in the space, and release and pull gently down on the larynx, or maybe sometimes not so gently. I mean, it's, it's a firm movement. It's gentle to the patient, but it's firm, or it won't move. And then, we talked about this a little bit, but the elements of the tongue, the floor of the mouth, the jaw, and all of the attachment, and the shoulders attaching to the hyoid. When you have irregular tension patterns or dysfunction in the larynx, you have a tense face, a tense state of breathing, tense diaphragm function, tense pelvic floor. And, if you have TMD, you can have significant pain, headaches, and that also impacts breathing and limits pelvic floor movement. So basically the jaw informs the pelvis, and we'll get into the pelvic floor because that's my baby. That's what I research. If you're interested, I can tell you everything you would ever want to know about your pelvic floor. And then I don't know if any one of you knows about this hyoid bone syndrome, but I thought I'd mention it because as clinicians, we're often going to be the ones that would say, hey, this might be what's happening. So if you have a patient who complains of neck and face pain, and probably some probably anterior and posterior neck pain and face pain, it could be this hyoid bone syndrome. And it's one of those things too that the patient will have tried like 4 or 5 different specialists and no one has any idea. They have their hands up in the air. So if you have somebody with this kind of description of pain, hyoid bone syndrome might be what's happening to them, and it's a pretty easy fix with corticosteroid treatment. So that would be a happy ending for somebody in your care. So hopefully that was a little bit of more in-depth session on the hyoid, how to release it physically, some stretching that you can use with all of your patients, not just people presenting with a high larynx or no thyrohyoid membrane space. What do you guys think? Good amount of information?
Yeah.
Not overwhelming?
Mm-mm.
I'll have more time next time. I just really wanted to get to know you a little bit on our first session. We didn't have everybody here, but how are you guys feeling about the frequency of meeting? Is once a month good? Would you like twice a month? What feels right?
I think twice a month might be good.
Okay.
I don't know what other people think.
Yeah.
Yeah, I agree with that.
Okay, awesome. I picked Wednesday for tonight because I would say, I think almost everybody could do Wednesday. There are a couple people who could only do Thursday and Sunday. So I'm happy to do another poll just for our group and see if we can find a time. I can also, is weekend like morning time ever a possibility for any of you? No. Okay. Probably just the days that I suggested were the best ones. Okay. I do feel like I should at least do one of those days, like a Sunday night, so that some of the people who couldn't be here tonight could participate. I will always send out the video afterwards, and I'll send you a handout of what we covered tonight so that you don't have to worry about taking notes. You can just be present, because I really think that if you're participating in the exercises that I'm giving you, you're going to learn this information and you're not going to need to write it down. And I promise that I will always send it to you afterwards, but I really want you to be present and actually doing the work so that you're embodying it, you're understanding it, and you're feeling the benefits of what we're working on. Good.
Mm-hmm.
So great to meet you. I might suggest I could either do next Wednesday or next week sometime, or it would have to be the end of January, because my husband and I are driving back from Mexico to Denver, and often there's no Wi-Fi or not good enough to do Zoom kind of Wi-Fi. So I'll reach out as far as our next meeting, but I'm excited about doing twice a month. And please never hesitate to just email me. You have my direct personal email, and just ask me questions. And if something comes up, even if we haven't gotten there yet in our little webinars, I'm happy to help. That's why I started this group, because I really want to give you as much support as you can get to be successful clinicians. So, and I know a lot of you already are there. So, so great to meet you all.
Yes, thank you.
Sorry I went over a little bit, but have a great rest of your evening, and I will be in touch about our next time.
Thanks,
Thank
Kate.
you.
Thank you.
Thank you.
Everyone.
Thank you.